Kunal? Okay, let's find. Do you have access to NBI? So let me try and understand what are the challenges to use of NBI. If you have, using it optimally, you are using it suboptimally, and not using it, and why?
We are using it occasionally only.
Okay, so it is very suboptimally.
Yes.
Why?
It is only one scope we have,
Fine,
190.
whatever.
Yeah, so that if there is 5 or 6 processes upper J, then we need to reprocess it. So we have 3 series. Usually we use.
You use 150
Yes.
and don't use the 190.
Yes.
Why? Because you're sort of preserving the scope for thing. Is that
Yes, sir.
you don't
We
want?
usually use it for third case or any suspicious lesion only, not for routine.
Okay. Yeah, which means that if I understand you right, that with 150 or whatever you're using, you're finding suspicious lesions. So there is no problem of picking up suspicious lesions with the older scopes.
Yes, sir. We fairly get this thing. If we are suspicious lesion with 150
No,
series.
no. So simple answer is you are able to pick up suspicious lesions with the older scopes.
Older scope.
Okay. Dhaval, let me ask you, your, uh, are you using NBI optimally, suboptimally, or fairly?
Suboptimally.
Suboptimal. Why? What is the challenge?
So one is the same thing that we reprocess the scope and we do
The other scope doesn't have NBI.
no, we have one pair of 190. There we have two 3 pairs of 150.
So you also have 150. So, but when you use the 190, you do an NBI in all patients? Do you use an NBI focus in all patients?
No, not in all.
When you use an NBI, when you use a 190 scope.
Same like so when 150 we suspect anything, then we change to 190.
So you never use 190 upfront at all.
Uh, when we suspect like a screening Barrett's or we are already suspecting something, then on history or some other investing, then we use upfront. Otherwise, after 150.
What's the difference? 150,
It is around 2029, and that 150 this thing that is 10 to 12.
So the big cost difference. But suppose I tell you that you do 50 cases of with the 190 series or the higher end scopes, you pick up a lesion, you end up doing one ESD or EMR or whatever. Then how does it work out? Does it work out okay? Or you increase your cost for all procedures by another 200 rupees and use 190. Suppose you do 100 procedures a month, you are now picking up 200 into 100 कितना होता है?
हमारे यहाँ 180 200 जितना होता
200
है
rupees,
फ्री गेस्ट
200 rupees into 100
नहीं और
कितना हो गया? 20,000 per month you will make.
नहीं वो
So
प्रोसीजर
per year you will make.
सर यू आस्किंग चार्जेस
Huh? Suppose you increase your charges. Suppose your gastroscopy charges 2,000. Suppose you add 200 rupees to it and do everyone as 190. You will earn another few lakhs a year, which will pay for itself. उस पे डालो NBI advanced endoscopy डालो. What is stopping you from doing it? What, Nishant?
Maintenance.
Why is this cost difference so much between 150 and nothing or 170? But then are we encouraging thereby less optimal use of endoscopic thing?
So just to give you one heads up, this year onwards, there is some pricing reduction in 190 series of H1 H scopes, which has been now going to be updated. And 170 series, which I think we generally promote that because that's a scope that has the NBI usage for all the procedures. Optimally priced, I think it's in between 190 and 150.
Okay.
So I think that's where we encourage people to use.
Okay, how many of you say, okay, suppose Olympus gives all of you one scope of 190 at the same price as 170? How many of you will do NBI? All of you will do. So you're convinced that NBI is worth doing. There's no problem on that. How many of you will still say that I've got a lot of endoscopy load?
Current stage of practice, we have a time to do. Current.
So how many of you will say that even if you give me 190, I won't do?
Time we can, this MBA is going to pay you. It is not going to, when you can double the procedure charges of 10,000 procedure, at the same time you can spend this with the patient and you can earn the same. So time you can, it is all about, we are concerned about the number of cases, number of the means payment, what you get for that. So if you increase the charges of, we get the charges of MBA, we can spend the time for half an hour for diagnosing the case. In our setup it is different, we are a three, so one can do for MBA, one can do EMR, ESD, one can do other routine gastro.
No, because if you look, even with sitting and teaching and thing, we didn't take too much time. So it doesn't take that much time actually.
I think when there is a lot of people have an MBA scope, then I think people will start practicing because it's just a matter of clicking one button and it will give you a good result.
So it actually doesn't take too much effort or time. So I think the block is more mental that thing more than anything. That's what I'm trying to address. See, because I have gone through the same steps as you have. Maybe there's no time, but you realize that actually it works out much better.
Second, this MBA workshop is not frequent. If you see US workshop and there is much more frequent workshop across the country compared to MBA.
No, but remember that if you don't master NBI, where is your EMR ESD going to come? It's not going to come. So that is the first step. You can't say I know how to do an ESD if you don't know how to assess the lesion.
See, currently, sir, the patients who are selected for EMR and ESD, they are not passes through the phase of MBA in our setup. Means whatever in Ahmedbad, they doesn't not routinely pass for MBA.